Hello, Internet. This is Sophia. My special guest today is Dr. Laura Berry, MD resident, physician pathology and laboratory medicine at Pennsylvania Hospital, Penn Medicine. Welcome to our show.
Happy to be here, Sophia.
So today, for sake of context, I'm mentioning that today is May 26, 2020. Could you give us some idea of the latest numbers associated with this disease as it is at this point?
Sure thing. I was looking at the numbers earlier this morning over coffee from the Hopkins aggregator website, which has beautiful data visualization tools. Currently in the US, we're standing at about 1,665,852 confirmed cases.
COVID-19, you mean?
Yes, of COVID-19, the disease that's caused by the SARS-CoV-2 virus.
Yeah, and
Now, if we want to break down those numbers a little bit more, so far we have a unfortunate death rate of about 5.9% so far recorded. But good news is that 22.7% of the reported cases have shown to be recovered, either outside of the hospital or have been released from the hospital. Of course, the discrepancy, the remaining cases either are lost to follow-up or they're still in the process of recovering from the illness, either in the hospital or in self-quarantine at home.
now, one thing I'm wondering if we have information. Do you have information on the breakdown of just the people who were diagnosed long enough that we'd expect them to be either dead or recovered by now? Do you have the breakdown of the survival rate of those diagnoses that are that old?
I mean, most of the cases where we have information about the approximately 25% of people who fully recovered from the disease are those people who were first diagnosed during the initial wave in March and April. It's a disease that sometimes, like the flu, can have some lingering effects. There was a friend of mine, actually a colleague of mine, who was in the ICU and in acute care rehab following his intubation on a breathing machine for 63 days. He just recently was able to come home. So it has a very long recovery time. And so I think, especially the more severely that you're affected. So I think that's why we're seeing those numbers lagging from the, the deaths infected versus total infected versus recovered.
Now, there's been rumors I've heard of people who were previously pronounced as having recovered from COVID 19, but then were tested again positive. Does this say anything about the level of our ability for the immune system to handle and gain memory of this disease?
That's a really valuable question. It's something that we've been concerned about from the very beginning when reports started coming out of Japan that people had recovered after having tested positive, then tested negative up to 2 weeks later, and then later on follow-up, they either had more symptoms or they were just in routine follow-up because this is a new virus and that's, we're trying to keep track of how long it stays in the system. Up to 2 or 3 weeks later or a month later, they would show positive again. It does, I think, speak to two different things, and they're difficult to tease apart as variables. We're not sure if this virus is something like chickenpox or shingles virus or herpes, where it can stay latent in the body for a long time and then reemerge to resume infectivity or symptomology. I think that's something that we will see that's not very common for coronaviruses, but it is certainly a possibility. This is a novel virus, and we're not 100% sure, how its life cycle proceeds in the human body. However, I think it also speaks to the testing situation that we have. Initially, the lab-developed tests for, at least in the U.S., there was a high rate of false negatives, somewhere between 20 and 40% of cases. And so it's possible that with the patients in other countries that have had recovery and cleared the virus and been tested negative, it may not have been a true negative. It may have been a false negative, and that's why they reappeared or seemed to reappear as a positive test later on. They may have never been negative to begin with.
I see. There are people who have expressed concern that the fear about the COVID-19 pandemic is overblown. What would you say with regards to that?
In terms of people having skepticism about the validity, the reality of what's been going on. I mean, I've seen that. I've seen that in on my news feed. I've seen it on videos online. I've heard it even from the mouths of my own family members. It's something that I think is exacerbated by the fact that everybody is on some degree of a lockdown or self quarantine. The sick people are being isolated from the well in the hospitals, and so unless you know somebody who works in a hospital or you know somebody who's become gravely ill from this disease, it's very easy to look around and say, what's going on? You know, I don't see plague carts going up and down the street. I don't see ambulances coming to my neighbors' homes. You know, is this really as bad as everybody's making it out to be? And I think it's sort of like what happens with vaccines, where it's a little bit of a victim of its own success with the procedures, the preventive procedures that many states have put into place. People just simply aren't seeing the situation on the ground in the hospitals.
Or in the field of computing, the famous Y2K bug that many people might think was a false alarm because the disaster never happened, when really the disaster would have happened if the computing industry hadn't scrambled to prevent it.
Exactly. It's you know, if everything works, then the preventive measures, people will say, oh, we overreacted, you know, nothing terrible happened. And in that case, you just kind of shake your head because you're like, that was what we were hoping, you know? So it is, yeah, it is a bit confusing and difficult sometimes to explain to people.
Um, um, well, anyways, to anyone who follows this video, it should be noted that, yes, sorry, to anyone who follows this channel, it's pretty clear that I do know people who have been previously infected with COVID-19. As a matter of fact, sometime a few weeks ago, I actually interviewed a COVID-19 survivor, and I will provide a link in the video description to that interview and maybe one of those YouTube note card things here for you to follow to that interview if you like. Anyways, what are the best practices for containing the spread of COVID-19?
I think we can break that down into a couple of different spheres of control. The personal, which is how you and your household and loved ones respond to protecting yourselves and each other. And then the larger scale of preventing transmission in the community, in and out of hospitals, in nursing homes, things like that on a wider scale. On the personal level, general good hygiene practices, washing your hands, washing your face, not touching your mucous membranes, that being your mouth, eyes, nose, without having washed your hands recently, using hand sanitizer, practicing social distancing, kind of staying away. I don't know if anybody's ever seen one of those videos of what it looks like when somebody sneezes and 400 miles per hour of droplets get aerosolized out several feet. things like that. Just maintaining a distance from others, that you're not in contact in your home on a regular basis is a safe thing. And that's where the masks come in, both to protect yourself and also to protect others. If you happen to be an asymptomatic carrier, or if you happen to come into contact with someone who is a carrier.
And could you let my audience know what are and what are not the goals of these containing practices?
Absolutely. I think the best summation would be what we were saying in the beginning, the flattening of the curve. Um, the goal is not to contain or quarantine this virus from infecting people anymore. It's reached pandemic status. The horse is out of the barn, so closing the barn doors is not going to be helpful at all at this point. It's going to spread through the population. And what we're trying to do with these containment practices, closing down high density interactions in public, like bars, movie theaters, restaurants, concert venues, things like that. And then, practicing basic hygiene. It's just to slow it down so that it burns through the population at a level which our hospital system has the capacity to deal with. And I think that we've been incredibly successful in the United States, outside of a couple of very high density areas like New York City, which is, I think, an exceptional situation globally compared to what's going on in any other country, or frankly, with the rest of the US.
Does that have anything to do with the fact that New York is a city which is like connected to the entire world, like a hub of the entire world?
Exactly. It's America's most international city. I think it's a world city. People are traveling, probably millions a day on a regular basis, in and out. Um, you have people coming from Europe, from China, from Russia, from everywhere in the world, and mingling together. And so you're going to have it's going to show up first there, and it's going to spread very, very quickly there. I mean, even compared to the city of Philadelphia, New York's on a whole nother level. It's an order of magnitude in terms of difference in the way that um, viral modeling, and it spreads through populations. So I think that is an exceptional case that maybe can only be compared to other cities of its size and density.
Kind of like the Constantinople of today.
That's actually, yeah, yeah, really, it is.
Um, there seems to be a great deal of confusion about when people do or don't need to wear masks. If you're outside and there isn't anybody near you, do you need to wear a mask then?
I don't believe so. If you're out, walking on a footpath or out on the sidewalk, and you're the only person you can see in any direction for a block or a couple of quarter mile, if you happen to be out in nature, um, you're not protecting anybody by wearing a mask there. I think having a mask available in the chance where stop off at a picnic table, and there's families nearby, or people, you see somebody coming down the path the opposite direction. That's where something like that, where wearing a mask, practicing social distancing, really has the most value.
And how close does somebody have to be before you need to put that mask on?
I'm sorry, there was a little interruption there. Can you repeat the question?
How close does somebody have to be before you have to put that mask on? It seems like we have some technical difficulties.
Yes, I've just got you back now. I don't know, but we can. keep moving on.
I seem to have lost the video. Lost video.
Gosh, okay. See if we can get that back up. I've got video on you. I don't know if it's still broadcast.
I see a picture of Mabel Pines.
Oh dear. Okay. How about I'll hang up and then you can call me back?
Okay, you could try that.
Yeah. Hello?
Hello? Okay, so it seems like um, so it yeah, good thing that I'm doing this thing where we have the raw footage block, which will be really only visible to the public for the sake of full disclosure and
No, I agree. It's good to
and
have the full thing there, but I think definitely the
should be
polished
the
product will
first.
really be the
Yeah,
best.
this incident is why I'm doing. So what was I saying when? Okay, how far can somebody be before you have to put that mask on?
So if I heard correctly, that's how far away or how far apart can somebody be before you're worried about person-to-person transmission?
Yeah, and when if you're outside, you don't see anyone for quite a distance, and then you see somebody coming. How close can you let them get before you have to put on that mask?
Sure. I mean, for myself, just because when I'm used to wearing a mask, doffing and putting on, donning and doffing, for me, it's very easy. I can do it quickly without thinking very much about it. For people who aren't in the healthcare field or aren't used to wearing face coverings, it may take them a little bit longer to feel like they have the mask on securely or comfortably. I usually give myself, if I see somebody coming down the street, um, and we're on the same sidewalk, I would say maybe 2 car lengths, 3 car lengths, just enough of a distance where I have time to, if the mask's, down on my chin or if I'm carrying it, to, quickly loop it up over my ears and put it on so that by the time we're in that, 6 to 12 feet, I'm already protecting that person.
Now, let's say you're in an indoor garage of where there's like of an apartment building, the indoor garage of an apartment building, and there's nobody else around. Do you need to wear a mask then?
Through once I've left the contained airspaces of, say, an elevator or hallways in my own building, I've taken off the mask as I walk out into the outdoors. But you have to keep in mind, anytime you're removing a mask or putting on a mask, that's an opportunity for your hands touching the outside of your mask, having touched doorways, things like that, touching your face. So the number of times that you can minimize touching your face by removing and putting the mask on again, the better. So if I know that I'm going to walk out and go down to, say, the grocery store to pick up, the necessities, and I'm just going to be walking a couple 100 feet, I'm not going to take my mask off in the garage, even though there's nobody around and there might not be anybody on the sidewalk as I'm walking. But I know when I get to the store, I'm going to have to put my mask on. I'm going to have to touch door handles, handle produce, things like that. And so I'll just, for convenience sake, for safety's sake, I'll leave my mask on.
So if I understand you correctly, what you're saying is that when you're in the garage by yourself, the only issue of not wearing a mask then is not contaminating the air, but just the issue of putting the mask on and off, even if it's a
Absolutely.
even if it's an apartment, even if it's an apartment building's garage shared by the apartment building, if no one's there at
Yes.
the time.
Yeah. It's one of the same reasons why, like when I'm at work in the hospital, um, even people who are seeing patients, they have the N95 and then they have the paper mask over top. If they're going out of the patient's room, um, they'll remove the outer mask and walk in the hall, but have the inner mask on, and then they'll put on a new disposable mask over top for the next patient. They don't want to necessarily be removing both masks, be touching their faces, things like that. I think that's the biggest issue with the removal of PPE.
If you think that you may have already had COVID-19, do you still need to wear a mask?
So if you know that you had it, if you had symptoms, after the start of the new year, and you spoke to your doctor over the phone or telemedicine, and for whatever reason, because there was a shortage of tests, you weren't able to get a confirmatory test, a diagnostic test from a nasal swab or something like that. But you did, take care of yourself and self-quarantine for 2 weeks. It's in the absence of having confirmation that it wasn't some other respiratory virus like influenza A or respiratory syncytial virus. I think it's in both your best interest and the best interest of your, family, friends, and community to continue practicing social distancing, wearing a mask, because you can't be sure that you actually did have the coronavirus unless you have the positive test, which a lot of people didn't have the luxury and still actually don't in some places have the luxury of knowing. Um, in addition, I think the universal mask wearing is a reminder um, to ourselves and to others that we're kind of all in this together by the nature of infectious disease. And seeing other people wearing a mask will remind you, oh, I shouldn't be touching my face, or I should wash my hands, or when I cough, I'm going to cough to my elbow. Just it's a visual reminder that things are still, developing, and there's people out there that are vulnerable.
Because a COVID survivor that I interviewed is somebody who he he himself was tested. His wife was presumed to have it also, but was not actually tested. I, of course, do not know. I don't remember whether or not they specified whether they wear masks. I'm assuming they do, but hypothetically, there could be other people in the same situation where one member of a couple was actually tested positive while the other is believed to have had it but wasn't actually tested. Um, and you're saying that then that's still not sufficiently certain.
In that context, if you did have a close contact who tested positive, and then for the conservation of test resources, their loved one had the same symptoms and recovered, I think it is safe to assume that they were infected with the same disease. Um, assuming that it happened within the same reasonable infectious transmission timeline. Um, we don't know that the antibodies produced by the human body against the COVID-19 virus are 100% protective against reinfection. I think that's something that's still developing as people are slowly recovering from this. So, and we don't know how durable of a recovery that is. So we don't know if the spike of antibodies that comes after an illness will protect you for 6 months, 2 years, 10 years. We don't know that. So, it might be fine. It might be like the seasonal flu where you've had the flu before in your life, and there's between the time that you had it, had the antibody response, recovered, and then been reintroduced with the virus again, it's mutated, or your body has simply not retained that durable antibody response. We don't know. Some viruses, you catch them once and that's that. Some you retain susceptibility throughout your life because the immune response is not something that is durable. So I think until we really understand the life history of this virus, and that's just going to come with time, I think it's prudent to protect yourself and protect others. We don't know how long people shed live virus for after they've been infected. We assume it's 2 weeks because we've seen people clear the RNA, the nucleic acid of the virus after that period of time. So we assume that they're no longer infectious. But you know what they say about assumptions. So I think it's reasonable to to protect both yourself and your neighbors and community until we really understand how this is going to develop.
And just to be clear, I don't remember if the COVID survivor whom I interviewed specified where he and his wife are with regards to mask wearing. I don't remember if he specified it, but I just had asked this question because I know that if there's one couple that's in that position, there could be hundreds of couples in that position. I just wanted to make that perfectly clear. Now, and so I guess then that the possibility of previous COVID-19 infections then also doesn't affect what other protective measures you have to do either then, right? Like the 6 feet and everything.
Yeah, I think until we really get a better population level understanding, once we've had enough people infected and recovered, and the FDA gets a handle on testing the quality of the antibody tests that are out there. Many of them are only preliminarily approved under emergency circumstances. They haven't been individually tested with rigor. I think it's going to be some time before we really do understand the landscape of how this virus functions in the human population.
Now, here's the thing is, if I were right now to be tested for COVID-19, could you describe the procedure, what would be done?
Sure. That's actually as part of pathology and laboratory medicine. My colleagues at the Hospital of the University of Penn were working on developing an early test, even as far back as January. So I'm somewhat familiar with the process. The first thing is that you would, if you're a healthcare worker, the workplace screening is available, so you can go to Employee Health or any of the testing stations that are set up in your city by contacting your employer and just have a walk-in situation. If you're a regular member of the community, you don't interface with the hospital, what you would want to do is if you really think that you are currently infected with the virus, that you have symptoms, shortness of breath, fever, malaise, really feeling ill.
You were garbled for a second. You were garbled for a moment.
Okay. I was just describing the symptoms that you would want to call your doctor if you thought you had COVID-19. Shortness of breath, fever, things like that. What you would do is you would call them or you would do a telemedicine appointment and you would ask for a prescription for a test. Most sites, you do need to have a doctor's note or doctor's approval for them to administer the test if you're a member of the lay public, just because there's a limited number of tests still available. We're still ramping up testing and it's not where it should be. So we don't want to waste tests on people that are just curious. We want to keep it for people that are really do, have questionable symptoms. So what you would do is you would drive up to a testing site, and then a nurse or healthcare administrator professional would come up dressed in appropriate protective gear. So face shield, face mask, hat, bonnet, full coverage gear, like kind of like what you would see in the operating room. You would roll down your window. They would either take your script or they would talk to your doctor, or they would have called ahead. And it's an unpleasantly long Q-tip. I know there was a video conference where the president was referring to them as Q-tips. They're a little bit more complicated than that. They're actually not a cotton bud. It's a special plastic flocking that's designed to capture the viral material in the mucus. That's one of the reasons why it's not so easy to make up for test shortage and test equipment shortage. But it's a fairly long swab. It's inserted gently into the nose as far back. They swab uncomfortably around for about 15 seconds in each nostril, and then they return that to a test tube. And depending on the severity of your symptoms, they can decide how to process the test. If you're doing okay, you can breathe without oxygen assistance, you're feverish, but it's no worse than a regular flu that you would have, they may send you home and then they'll give you a call back in 1 or 2 days with the results. If you're really looking in bad shape, if they say, we probably should be sending you to the emergency room, we're worried that you're not going to be able to keep breathing through yourself, you're turning blue, you're not oxygenating. In that context, they would obviously triage you to enter the hospital, and they would use the more rapid return tests, which can return results in as little as 30 minutes.
So I imagine that it would be very uncomfortable having that test done.
Yes. I haven't had the COVID test on myself, but if you remember going to the doctor as a child with a sore throat, they'll have those very swabs that they'll swipe the back of your throat and it makes you gag. It's a similar type of tool, but inserted through the nostril. So you don't get a gag response, but it is uncomfortable. It's not something that most people are used to. So yeah, it's not painful. It doesn't damage you or hurt you in any way. It's unpleasant.
With my finicky reflexes, I better stay inside.
I can't say I would go and be tested out of curiosity. No.
Now, there's been a lot of talk about the role of privilege dynamics that affect how much people are able to comply with guidelines for containing the spread of COVID-19. What would you say that people in a position of privilege can do in order to make compliance with these guidelines a bit more viable for people who don't share their privilege?
Absolutely. You are correct. There's a strong dynamic of sociopolitical, ethnic privilege, economic privilege that's winding through this whole developing situation. Like in much of public health, people that don't have a salary job that direct deposits a paycheck every 2 weeks that allows you to remotely work from home. You have to have internet, you have to have a computer, you have to have a job that allows that. It's not something that everybody has. So, there are people that are, janitorial staff, delivery workers, restaurant workers, essential personnel in transportation, people that work at the registers or stocking shelves at the supermarket. All of these people are, they're necessary. They are going to work. They don't have access to the level of PPE that, say, a hospital worker does. And so they are at higher risk. I think if you are somebody who is in a position of privilege, One thing you can do to, I guess, protect other workers is, minimize your interactions. Don't go to the grocery store every 2 days to pick up, $50 worth of whatever. If you have the luxury, go once a week, go once every 2 weeks. Don't go and just don't go out of your way to make things more difficult for the people that have to be at work, that have to be out and about. I think I've been tipping my delivery people that have come delivering packages or food. I've been tipping them in cash or on Venmo, just if they don't want to handle cash because they're worried about virus transmission. Just because if they have a little bit of extra money, that may mean that they can take a day off, and that's one less day of exposure for them. So I think having some sympathy, having a little bit of generosity financially can be helpful to people. Additionally, I mean, for people that you don't come directly into contact with, another thing that you can do is contact your local representatives on the state level or on the national level. There's talk about, relief checks going out in addition to the one that was sent out earlier this year, expanding unemployment benefits for people. And I think that's something where if you have the luxury of time and effort, that's one way that you can try to help out other people who are disproportionately affected.
Is there a such thing as going too far with regards to cautions related to the pandemic, whether it be too much hand washing, too much social distancing, whatever? Is there such thing as going too far?
I think so. I think there definitely is. Just like we can't act like we have to put on a spacesuit every time we leave our homes. It's not practical. It's not particularly any more helpful than routine hygiene practices, and it's frankly not mentally healthy, I don't think. For people that are not at disproportionate risk, so for example, they don't have an immunocompromising condition where they're taking immunosuppressive medications or they have cancer or they're elderly, I think it's not a good idea to necessarily isolate yourself in your home with no contact with loved ones or your community at all for months and weeks at a time. In the same way that it's not possible to remove all the germs in the world. It's not possible to sanitize yourself from head to toe, and I think it's not reasonable. It's not a reasonable response. There's having an abundance of caution, and then there's bordering on something like a compulsion or an obsession. And I think that is difficult for some people to realize where, with the fear, the culture of fear that we have. I think people are difficult. It's difficult to say what that line is these days.
With this pandemic having a lot of impact on everyone's lives, a lot of us are hoping for a vaccine but realize that there's no telling how long it'll be till we have one. Is there any treatment besides a vaccine, possibly a treatment that can come sooner than a vaccine, that'll make it safe for some degree of normalcy to return to our lives?
So if I heard you correctly, it's in the interim period between now and when a vaccine is developed. What might be some development, either scientifically or socially, medically, that can allow us to get back to to a more normal sense of social life. Is that what I heard?
Yes.
Yeah. Certainly. I mean, that's the goal of flattening the curve. We have been very effective in slowing down the number of people infected on a given day or over a given week, so as not to overwhelm the healthcare capacity. And we used a very blunt tool, which is total lockdown, closing all the restaurants, schools, many places of work, many public spaces, in addition to also encouraging people to wear masks, have hygiene, and then practice social distancing. Um, I think what will happen is going forward, people are not going to be comfortable or tolerate psychiatrically or socially or economically being trapped in their homes. It's just not a normal way of life for human beings. Um, I think what will help us going forward to sort of relieve some of that unusual pressure is tracking the infection rate. And so if you live in a more rural or suburban area, and there have been fewer infections over a period of time, and it seems that it's on the decline, the local government has the authority to relax certain restrictions. So they'll say, oh, we're going to open up public parks, and we'll see if people mingling about in the space while still maintaining some degree of social distancing, if there's any spike in infections after that. And if there isn't, then maybe that's something that is, can return to some sense of normalcy. Same thing with grocery stores, certain office workspaces, things like that. I think we'll be seeing more of that in the coming months, especially in rural and suburban areas. They'll relax some of the lockdown conditions, see if there's any response and spike of infections or not, and then if not, then we can proceed with some sense of normal lifestyle. Another thing is perhaps if there's a medication regimen that is found to be particularly effective against the virus. We don't have targeted antiviral medications for the coronavirus that we do for other viruses, such as herpes or HIV. Right now, we're using a cocktail of empiric medications that are mostly supportive and for controlling the symptoms, and we're relying on the person's own immune response with a lot of additional help to recover. If there is a development of a medication that can be used as a targeted agent, a targeted antiviral drug, that would be fantastic. That would be very helpful. It would relieve a lot of stress on the healthcare system. People may not have to be in the ICU for so long. And so, we wouldn't have to flatten the curve so aggressively because the healthcare resources would not be utilized as intensively as they are now. So I think those are two of the things that, while waiting for a vaccine to be developed and released safely, that we can look forward to, to return to normalcy.
So, any closing comments that you'd like to make? Well, hold on. Any close? So, any closing comments that you'd like to make?
I thank you for reaching out to me and organizing this interview. It's been really interesting to talk about all the different topics we touched on. I really appreciate that as a friend and as a medical professional, to be able to speak to people who are interested in getting ideas and opinions and facts about what's going on. Just be patient with one another during all of this. Tensions are high. It's complicated. Nobody's done this before. So be kind. Wash your hands. And I think we'll get through this together. It's every day, one step at a time, and we'll be able to deal with this.
Anyway, my special guest has been Dr. Laura Barry, MD Resident Physician Pathology and Laboratory Medicine at Pennsylvania Hospital, Penn Medicine. I hope that you enjoyed this video. Please hit the thumbs up button and submit a comment in the comments area below. Share this video with your friends.
Maybe it'll go viral. It's something I don't mind spreading.
Yeah, that'll be one viral thing that you do want to spread. Share this video with your friends. Make sure that you're subscribed to this channel and make sure that the bell icon is hit so that you'll increase your chances of getting notification when I add new videos to this channel in the future. And until next time, see ya!